All right, let's step into what might be one of the most intense situations in a surgeon's career, the oral board exam. This isn't about reciting a textbook. It's a high-stakes conversation, a viva, that's all about testing, judgment, quick thinking, and grace under fire. So let's take a deep breath and step into the hot seat. Candidate, let's begin. Your first case, you have a 45-year-old patient. They're dealing with morbid obesity and, importantly, severe, long-standing gastroesophageal reflux disease. I'd like you to discuss your preferred surgical approach and, of course, the alternatives.
Thank you, examiner. So for this specific patient, my preferred approach is, without a doubt, the Roux-en-Y gastric bypass. And really, when you look at these two procedures side by side, you can see why. The Roux-en-Y on the left does two things. It creates a small stomach pouch for weight loss, sure, but it also fundamentally reroutes the intestines. This is a game changer for reflux because it diverts all those digestive juices far away from the esophagus. Now, the sleeve gastrectomy on the right is a great operation for weight loss, don't get me wrong, but it can actually make reflux worse, which makes it a poor choice for this patient. And just to build on that, the other common options are really not a good fit here, mainly because of that reflux. For a sleeve gastrectomy, severe GERD is a pretty solid contraindication. Same goes if they have Barrett's esophagus, which is a precancerous condition. The sleeve basically turns the stomach into a high-pressure tube, which is the last thing you want. And older procedures like the gastric band, also not recommended with severe reflux. So really, the patient's severe GERD is the single factor that points us straight to the Roux-en-Y as the best, most definitive solution.
Excellent. All right, let's change the scenario. Your patient had the Roux-en-Y. They come back to you 1 year later with acute, severe pain in the upper abdomen. What's at the very top of your list of possible diagnoses, and what else are you considering?
My number one differential, the one I absolutely cannot afford to miss, is an internal hernia. That is a true surgical emergency. After that, I'm thinking about things like a marginal ulcer, a narrowing or stenosis at one of the connections, maybe a bowel obstruction from old scar tissue, or a gastrogastric fistula. But honestly, my immediate priority is to have a super high index of suspicion for that internal hernia, because if you're slow on that diagnosis, the patient can lose a huge amount of their intestine. It's catastrophic.
And, a really crucial exam point here is to understand why these happen. The vast majority of these internal hernias are, iatrogenic. That means they happen because of something that was or wasn't done during the first surgery. Specifically, they occur when the surgeon doesn't meticulously close the potential spaces in the mesentery. That's the tissue that holds the intestines in place. It's a preventable, life-threatening complication, which makes closing those defects an absolutely critical step.
Okay, so let's talk about another one of those possibilities, the marginal ulcer. This is basically an ulcer that forms right at the new junction between the little stomach pouch and the intestine. The definitive way to diagnose this is with an upper endoscopy. The good news? We can usually treat this with medicine. High-dose proton pump inhibitors, or PPIs, will solve the problem in about 90% of cases. We only really think about going back to surgery for major complications, like if it perforates, causes a severe blockage, or forms a fistula. Very good. Let's move on to a new case entirely. You're in the process of consenting a 60-year-old patient. They have a cancer in the lower part of their stomach, and you're planning a subtotal gastrectomy. What are the key points you absolutely must cover during that consent discussion?
So the consent process here is a really important conversation. First, I'd explain the procedure in very simple, plain language. We're going to remove the part of the stomach with the cancer, along with the lymph nodes nearby. Then I'd have to describe how we put them back together, the reconstruction, so they understand how they'll eat afterwards. We have to talk about alternatives, even if they aren't great options. And then comes the big one, the risks. I'd cover the immediate stuff, like bleeding, infection, or a leak from the new connection, and also the risk of injuring nearby organs, like the spleen or pancreas. But just as important, I have to cover the permanent, lifelong changes, things like dumping syndrome and the fact that they will need vitamin supplements for the rest of their life. It's all about making sure they know exactly what they're signing up for.
The patient understands and consents. Now, I want you to describe the essential steps. Walk me through an open subtotal gastrectomy with a D2 lymphadenectomy for this cancer.
Okay, so the key steps of the operation. First, as soon as we're in the abdomen, we explore. We need to make sure there's no widespread cancer on the liver or peritoneum that we didn't see on the scans. Next, we start to mobilize the stomach and carefully divide its main blood vessels. Now, the real heart of the cancer operation is what we call the D2 lymphadenectomy.
This is a very meticulous dissection where we remove all the lymph nodes along the major arteries that supply the stomach. This is absolutely critical for staging the cancer and giving the patient the best chance of a cure. Finally, we use surgical staplers to divide the stomach and the duodenum, making sure we have a good, wide margin of healthy tissue, and then we reconstruct their digestive tract. And speaking of that dissection, this brings up a classic anatomical pitfall, a real gotcha that every gastric surgeon has to be on the lookout for. In a decent percentage of people, a major artery to the liver, the left hepatic artery, takes an unusual route. It runs right through the area we're dissecting. If you don't recognize that variation and you accidentally cut it, you can cause serious damage to the liver. It's just a perfect example of why you have to know your anatomy inside and out.
You know, when I'm thinking about what can go wrong after surgery, I find it really helpful to think in terms of a timeline. In those first few hours to days, I'm laser focused on the immediate life-threatening stuff: bleeding, a leak from our connections, and blood clots. Then, a few weeks down the road, we might start to see a narrowing or a stenosis at the anastomosis, which would cause trouble with eating. And then you have the long game, months to years later, where we need to be vigilant for things like ulcers, hernias, and of course, the nutritional problems that are almost guaranteed to develop. Thinking this way is just essential for good long-term follow-up. Finally, candidate, I want you to zoom out. What single overarching principle do you think underpins all of safe and effective gastric surgery, whether we're talking about bariatrics or complex cancer operations? Examiner, I don't think it's just one thing, but a triad of principles that work together. It's meticulous technique, a thorough, almost obsessive knowledge of anatomy, and constant, unwavering vigilance for postoperative complications. It doesn't matter if you're reshaping anatomy for weight loss or taking out a cancer. Those three pillars, technical skill, intellectual rigor, and relentless postoperative care, are what give our patients the best possible shot at a good outcome.